or connections, whatever. So we're on week 9. It has come up so quick. As I told you, it is fast. At the end, it gets a little bit rambunctious. So, you know, you guys have really kept up with it. Most of you have been able to turn in your pediatric assessment assignments. I did send a message yesterday with this week's stuff. If you did not, you still have till Sunday to get it in with a minus 10%. Any of those assignments that were due. There was NCLEX, there was diabetes due. Quiz, I can't reopen unless I've been told something prior to it closing. So that I can't reopen. But the pediatric assessment, 6% of your grade. So please go back. If you didn't get a perfect score or at least a 90, go back, find out what you need to redo it by Sunday. If you had submitted it before yesterday midnight, I'll accept it without a deduction. So just go back and redo it, okay, if you want a better grade. I know you're up to here, and some of you are like, yeah, I'll take that 90, I don't care. But there are some students that I got to get that 100 because, you know, I'm a 100 sort of kid. You know, that 4.0 GPA. That was me in my BSN, MSN, and my PhD, 4.0 GPA. I was OCD to the max. So I understand those of you who are. So if you want to go back, I have made comments. I did keep up with all of those assessments during this holiday weekend, and I did send them back as soon as I could. I think the one day I was a little bit slacker was on Friday, but even on Thanksgiving, I looked in there earlier and later at night, and Saturday and Sunday, I spent a couple hours going over them. So if you have a some sort of comment, read it, and then if you redo it, let me know. Just send me a message so I can go back and see if I can adjust your grades at all. So this week is neuro and muscular dysfunction. There's some really interesting things here. And we, of course, we have our PowerPoint, and we also have our Kahoots to follow with it. Does anybody have any questions, comments? You know, I'll tell you one comment. Most of your assessments were amazing, and I could see the amount of work you put in it. And I appreciate that because I learn from what you give me because I read them, I look at them, I see them. There's some diagnoses I don't get much, so it is nice to read about them, and maybe I'm learning more. So you're teaching me, and I like that. So let's go ahead, let's start with our PowerPoint. I still have a cough. My grandson gave me this one now. So move this over there. So I guess I'll cough until Christmas, right? Musculoskeletal or articular dysfunction, bones, tendons, ligaments. You know, that little baby up there, anybody have ever seen a child that had their hips not in the right socket and have to be in this little Pavlik harness? It is something that without surgery, no physical therapy, just putting it on 23 hours a day, we can put those hips back in the socket, hopefully. So immobilized children, you know, kids, because of many different things, they are immobile. Could be a congenital defect. Maybe they had myelomeningocele and they have weakness in their lower extremities and they can't walk. Degenerative disorders, osteogenesis imperfecta. What a word, huh? It just means brittle bones, which means their bones break very easily. We know any infections or injuries, we know those can cause it. And there are therapies that we can do, whether it is nutritional or maybe it is a physical occupational therapy, one of those. So what happens when a child, an adult, cannot get up and move the way they should? Well, if you're not using your muscles, guess what? You're going to lose muscle tone. So you're not going to be able to bend your joints, full range of motions. So our goal would be to continue that if we are thinking this child or adult will walk in the future. Their bones become demineralized. This calcium balances goes on. And then cardiovascular, you're talking about your heart's pumping, but not effectively. The blood's not moving. You know, you're getting some venous stasis. Of course, blood clots, absolutely blood clots. And of course, that dependent edema. Now, how about a kid? Kid can't get up, move around. You know, they're stuck in bed. They don't got a wheelchair yet. Can you imagine that feeling of I can't move and I'm stuck in this little, you know, four walls? So it does become a very difficult time, a feeling of being frustrated, helpless, and they might get angry at you and aggressive because they don't want to be there and they don't know how to express it. Many of them do regress though, start sucking their thumb again, or maybe even, you know, being incontinent because of this immobilization. Now, let's say your kid is going to be immobilized for a long period of time. Maybe that is that myelomeningocele or a cerebral palsy who can't walk because it's too spastic. You know, it really affects the entire family. You know, all the family is going to have to pitch in to help, you know, and many times other siblings get upset because every attention is paid on that kid that needs special needs, not me. And sometimes we have to remember that. And as nurses, you need to remember that. Maybe having the kid who's immobilized send a picture or a card home to the kids at home, because saying, I miss you, and making them feel special, like, oh, look what he did for me. That makes me feel good, okay? Or maybe the nurse is giving ribbons out, send one home to your sister, right? Those things, those itsy bitsy things makes a big difference. Now, families at home do need help. They do need assistance. They need all of the devices, walkers, potty chairs, commodes, beds, et cetera, et cetera. So make sure they get what they need. And then there are many, many groups. I know that in our hospital, there was family groups on cardiac, on respiratory, on neuro floors, cancer floors, and they had these little groups and families would get together and they talk about their concerns. And it really does help. There's little things, little tricks other ones have learned they can pass on. And of course, individual counseling, because it's rough, because you're, you know, as parents, you're angry because you can't get up and do what you want to do too, even though that is your child. You know, you think like, huh, how could you? Well, sometimes you do. And then you feel guilty for feeling that way. Now, injuries. You know, kids are always doing something, you know, falling down, twisting their ankle, their knee. We know that's just playing around and being a kid. Of course, it could be during sports. We could have contusions. Excuse me, sorry about this cough, guys. Like little Christian fell off the bicycle handlebars because he thought he could sit there without Pop holding the handlebars, fell down right onto his head and had this big, big lump. Okay, last week, do you know what he did? He was underneath this, he takes the cushions and forts and the couch in the living room and makes these little tunnels and forts, okay? He loves it, this creativity. We let him be creative. Well, he was really going really fast underneath on his hand and his knees, and he ran into the chair. Right on his eyebrow is a 2-inch laceration and a big, big black and blue eye today. So they can be dangerous, these black and blues. Now, what if he got a bruise on a finger or an elbow or a wrist or an ankle? That swelling could cause issues. So remember, swelling could impede blood flow, right? Just like the blood flow went into his eye and made him a black eye, okay? We have to remember that, where did the contusion come from? Was it a crush? Did something heavy fall on him? We need to look for different things according to different types of contusions. Now, dislocation, this happens more than you think. How about those little kids, toddlers? Usually you're swinging them by the arms and their elbows pop out. It's called a nursemaid elbow, right? And because their tendons, their ligaments are so stretchable. So you go to the doctor and they go and they pop it back in and the kid's okay. And then we just rest those arms. What about Down's children? They could put both legs over their head, but they could pop their hip joints by doing it. So dislocation can happen. Our goal is to get it back in alignment and rest it. And also making sure neurovascular signs stay the way they should. I think I sprained my ankles 100 times in high school and college. You know, I played a lot of sports. And it was always go up to spike a volleyball and down on my ankle, or running around the bases in softball and hitting that base wrong and twisting that ankle, or running to catch something. You know, it's something that happens. Remember, rice will always be what you do: rest, ice, contain it with an ace bandage or whatever you have, and elevate it, because all of those will help decrease swelling. And remember, even just a sprain, remember checking neurovascular and pulses. Strains are when you do something over and over and over again, and it causes a strain, like shin splints. Ever hear of that? That is a strain, you know, to your muscles. I know that children training for swimming or the Olympics or gymnastics, they're doing repeated things over and over again, and that causes strains. So again, we rice and ice, right? Rest, ice, compress, and elevate. And then, you know, today we're putting more casts on sprains than ever before. Years ago, you didn't. You just put an ace bandage on and you go. But today we found out if we keep it contained, it will align up better and it will heal better. Now, there are fractures. Kids do it all the time. You see this kid had those bilateral fractures of the wrist, right? You know those little hovercrafts that came out like 5 years ago, right around Christmas? And I was like, I don't know if I like these. Now, the kids, there was 2 boys, came into the ER that Christmas time, those 2 weeks off. They had both sprained bilateral fractures, radial and ulnar of both wrists, okay? And it was because they didn't have wrist restraints on, that braces that hold them, and they went to fall and they put their hands out. And of course, they fractured them both. So this is something that can happen. We sort of expect that. In an infant, you should never expect a fracture. If a bone in an infant is fractured, it needs investigation. You know, I've got stories about, you know, abuse in infants. And one kid had a fractured skull, fractured femur, fractured ribs, and a fractured humerus. And it was all in different stages of healing. So, and the kid was only 3 months old. And it was because the kid was crying too much and the father had to watch the child, and they were twins. So you think that it doesn't happen? It's hard. So just remember, as a nurse, what is your goal? Keep the child safe, which is what I did. Reported it to the doctor, what I thought. We did the x-rays, we found it. The charge nurse, we called in the police, we called in DCF, we did everything, and that child today is protected because of it. Types of fractures. Well, the normal ones that we get is they just crack and we need to put a cast on. It's a simple or closed. But sometimes the force of the fracture is so hard that sometimes the bone comes through the skin. Remember, if it comes through the skin, the bone has been subjected to the air around us, to the germs around us. So you will need IV antibiotics. And of course, you're still going to cast it, but you might leave a window where that open area is to be able to look at it. Then there's complicated, which goes, maybe the ribs goes into the lungs, or comminuted that's twisted and there's pieces all over. And it, depending on what it is, the comminuted, probably they're going to require, you know, pins and bolts to try to put it back the way it should go, and surgery. Now, children, the most dangerous, I would say, of all of the fractures is in their growth plate. And you could see where it is. It's like on that ball of the bone. And this is where your bones grow. So if we get a fracture, usually it's the elbow, I might say most of the time. If we do not repair it correctly, that arm is not going to grow properly. It might be shorter, might be crookeder, and we want it to be the same as the other side, especially if it's a leg, right? We don't want to have issues with that. So growth plate injuries are the weakest point. It's called the epiphyseal plate is the other name for it. And how do we treat this? Because it's so serious, we do an open reduction internal fixation with pins and screws and plates and holding that bone where it needs to be. It's just not a cast. Now, this I always thought was interesting. Look how quick infants, how quickly they heal, 2 to 3 weeks. So if you have a kid in, let's say they have that club feet, right? Put some casting on them, remold them. It could only take a couple weeks for it to get to where it could go. But, you know, early childhood, you know, they get it at the beginning of summer break. I think those are the hardest ones, and they can't go to swim camp, right? But after 4 weeks, those casts will come off and they can go and swim. But if it's an adolescent or an adult, it probably is 2, 3 months or even more. So how do we deal with x-rays? Well, number one, you're going to look at the child, see deformity, swelling, you know, and we're going to ask them, how did you do it? And sometimes if we're in the x-ray, I will ask away from a parent, especially if I see a kid all the time. Now, don't get me wrong. There are kids that are clumsy, that fracture bones, that, you know, parents or nobody had anything to do with it. But again, I have to make sure the kid is safe, right? So you do an x-ray, we see it, and then our goal is to reduce it, put it in a splint, put it in a cast, put it in a sling, whatever it needs to do, because we want to keep that arm, the leg, the foot, the toe, the finger, we want it all to be in the function that it should be. So when we get a fracture, we need to be looking for those 6 P's: the pain, the pallor, if it's capillary refill, right? Pulselessness, if we can feel one. That paresthesia means it's getting numb. Paralysis means I can't move it. And then swelling, that pressure. Now, this arm down here, black, is like the absurdly other end of the spectrum. But if we're not checking a cast, we don't teach parents about it. When we take a cast off, it could look like that. So just to let you know that we really need to be diligent ourselves and teaching our parents all about it. And the kids too. Kids will sit there and look and see their little fingers go from white to, you know, white, pink, and, you know, counting how many seconds, toes, fingers, whatever. Now, putting cast at home, you have a kid. Now, today, what's great about pediatrics, pediatric hospitals usually have all different colors. We had rainbows and we had army, we had yellow, 2 types of pink, 2 types of blue, red, green, purple, pink, red, black. I mean, any color we want. I mean, boys like to get their favorite football team if it's football season, right? Or their favorite baseball team or basketball team. And we could do different colors. And if you look at this girl here, it looks like a spica cast she's in, but even her doll has it on. So we make it more fun. And that's kids. We make it more fun for everybody. But how do we work with a child with a cast at home? Remember, we can't get it wet. You know, I've seen kids go home with a cast on their arm, put their bathing suits on and go run and jump in the pool. Come back, get another cast, 2 days later, do the same thing. I've seen one kid do it 3 times. And I told him if I saw him again, that me and him are going to have words. I said, your poor mother has to keep bringing you into the emergency room. So could you please stop doing that? And then the kid made me a promise and I never saw him again. Hopefully it never happened. Taking care of casts, we know a little hair dryer underneath, nothing sticking, no powders, no nothing. elevating after we get it, putting ice there. And there is all sorts of plastic bags that the hospital has for a short arm, short leg, a long leg, plastic bags according to size that we can put on, or just hold the arm out of the shower and take a shower, right? Or in a bath, keep the leg up over it. So there's ways of doing it without getting it wet. Now, not all type of fractures require a cast. Sometimes they need some sort of traction. Now, there's skeletal traction, and then there are skin traction. Now, skin traction, you see this one on the bottom? This is one that's called a Buck's traction, and it's to pull the femur out to hold the edges together until we could get to surgery and put a rod through it, okay? Because those little edges of the fracture site, if they're not together, it hurts and it's painful. Once it's put together by pulling it with a weight, the pain decreases incredibly, exponentially, okay? The thing about these type of tractions, there's a weight on the end. Make sure it's free flowing. Make sure you document that weight every day, and it must be on 24 hours a day, okay? So as I said, it could be to remove that fatigue of those muscles, like your fractured femur. It could be that there was a fractured neck, and we need to keep that neck in alignment till we can get swelling down and get to surgery. You know, we see the halo, you know, we see the tongs. You know, I've used tongs, you know, in a child who had a C5, C6, the cervical spine should be straight. It was angulated after his head went into a knee at third base playing baseball. And today, because I kept that head straight, I was the primary trauma nurse on duty, and that kid today is walking and has no neurological deficits. And it's because I kept that site immobilized. That, when you have any spine fracture, most important. So here we are, excuse me, different types of tractions. Well, Buck's, like I've already told you. Russell's is when it's sort of bent, and this could be also something to do with the femur, depends on physicians. And then Bryant's traction, where they're just up in the air, and that could be for those hip that are out of sockets there. So there's different tractions used for different things. There's skin traction here, and there is also your skeletal, which means there's screws inside something. Like this little halo, there's little screws that go into the skull. Sometimes we have to use what we call an external fixation device. Now, this is usually when you have an arm, a leg that is shorter than the other, and we could break it, separate it, and then the bone will heal and it will get it longer. And it's called an external fixation device. Again, there's screws going inside the skin into the bones. So site care, very important, okay? How do we clean it? Depends on the physician. Could be soap and water. Do we apply antibiotic ointment? It depends on the physician. Sometimes kids are born without legs or without a bone. You know, I knew a friend of mine, his daughter was born without a tibia. And there was no way at that time to put anything there, so she couldn't walk. So they did a below the knee amputation. And I met her when she was 5 years old. She came over to my house, took off her prosthesis and chased my kids around the house, up and down the stairs. And she had the best attitude. She used it as fun. She didn't feel bad about it at all. And she kept up with my kids. And that was saying something. Sometimes because of injuries, you know, infections, etc., we have to amputate. And we know if we have to amputate, it's like adults. Remember, there's that phantom pain. We have to have that stump in a way that we put prosthesis on it. And it's also going to be therapy, learning how to walk on these type of prosthesis. Kids love to play sports. They love to be competitive, you know, and if they're not sports, they're competitive in other ways. But if they are in sports, remember that kids tend to get up and go without that stretching like adults should do, like we've been taught. So there is problems with those injuries. Make sure that they have proper equipment, that they're supervised well, they get enough rest breaks. And of course, keeping hydrated today is a big thing, especially me in Florida. It's still 85 degrees here today. We talked a little bit about that overuse. Again, this is doing the same thing over and over and over and over and over again. And this is something that's real. So it's something that should be monitored, and we shouldn't get to that point. Now, I've talked a couple times already about that hip at a joint, right? It's called a developmental dysplasia of a hip, DDH. Girls are more than boys in this one. And if you look at that picture, it goes from sort of in the socket to not in the socket. So we want to get it all the way up so the ball goes into that socket. Many times they're down, but usually they're up higher. Now, what do we see in that kid with a hip dysplasia? That ball is not in the socket, it's higher. Well, that leg is going to be shorter, right? Also, if you look at their butt cheeks, the gluteal folds, one's going to be higher than the other. Also, you're going to hear that restricted abduction, and you're going to have positive Orlani, positive Barlow. You're going to hear the clicking. That's why these pediatricians take the legs and looking for a hip being out of socket first visit on your children, on your new babies. What is the treatment? Well, very easy. We put on a Pavlik harness because it causes abduction of the hip, and it gets the ball and socket to move down and go right into where it should go. Usually, we can, within the first 6 months, get it back to where it has to go. These things, these harnesses, must be on 23 hours a day, which means you take it off for a bath only. They sleep with it, they eat with it, everything with it, okay? So very important that we keep them on. Now, if it continues, we can't get it back down. Sometimes they'll put that spica cast on both legs with that wooden rod in between. And if that doesn't work, they have to release the tendons. They're too tight. They're not loosening to be able to come down. And that's usually later on by age 4. I mentioned club feet. Now, you don't need to know all the names of club feet. You just need to know the feet are crooked. They're wrong. They're pointed. They're inward. They're outward. They're up. They're down. They're all different stuff, okay? And how do we treat these? Well, we do what we call a Ponseti method, and it's called serial casting. Now, these children are put in a cast. They need to be changed weekly, because remember, they heal quick, right? So we keep putting them to where we want those foots to be. Once we get that foot where it is, they need frequent checking for the orthopedic to make sure that that foot is keeping the way it should. And of course, they're going to need physical therapy to keep it stronger. Now, I have seen infants get out of these casts. I have seen them walk into the emergency room with the child in one hand and the cast in the other. And I'm like, how did they get out of it? Because it doesn't look like they can. But infants are Houdinis, okay? And they will. Osteogenesis imperfecta, brittle bone disease. We don't know why. It's something that happens that these bones crack easily. Can you imagine if we don't know that at birth and you do a vaginal delivery? We probably have fractured ribs, sternum. Who else knows what else? Skull. I mean, any bone can crack. When we're handling these children, we have to be very, very careful. Just changing a diaper, holding a leg can cause their bones to fracture. So we don't know what to do. There's no cure for it, but we can give intravenous biphosphonate therapy. We can give calciums. We could do therapy, but very gentle therapy. And again, our goal is to keep these kids in a position where at least when they get too far gone, they can go in a wheelchair. We don't want them to be in a bed their life. We want them to be mobile. We don't want an immobile child here. Now, Lake-Calf-Perth disease is an aseptic necrosis of the femoral head, which means for whatever reason, the head of the femur becomes inflamed. And what do we see? These will be a kid who starts limping and their hip hurts. And the kid doesn't play sports, the kid didn't fall down, you don't know why. So what we'll do is we will do an X-ray and we'll see this fuzzy head of the femur. And how do we treat this? It's basically bed rest and NSAIDs, which will take care of it. And sometimes we'll put these children on some traction to hold that hip in position where it should be. Rarely surgery. But again, we just want to try to keep that head there. The immobilization lets it rest and it usually just goes away. And there's nothing more than that needed. All right, we're going to go into 3 different curvatures of the spine. Now, kyphosis is humpback. It's the upper spine. That's usually, you'll see this in older people, sort of bent over. Their head is in front of them. Could be because of the way their jobs work, et cetera, et cetera. It could be in children due to osteodystrophy, where chronic kidney disease, where they don't get enough calcium and vitamin D, and it could cause their bones, to become disfigured. Lordosis is the lumbar, lordosis, lumbar spine, and it goes in, okay? And again, could just happen. We don't know why. There are some syndromes like the Duchenne muscular dystrophy that can cause this lordosis. But again, it's an arch back. And the one that's probably the most common of them all is called scoliosis. It's the S shape of the spine. And what you see is sometimes you'll see it initially, but usually it's when you get to that pre-adolescent growth spurt, all of a sudden the spine gets crooked. One shoulder is higher than the other, that will limp because of the way it's at, and we don't know why. So this is pre-adolescence. This is that period of, body image, right? So how do we treat it? Well, do you see these braces? We put a brace on, again, 23 hours a day. And we also do physical therapy and exercises for them. Now, sometimes that curve gets really far. And when that spine curves so much, it presses on the lungs. So it becomes now more of an emergency because of oxygenation, because that lungs being compressed. So we need to straighten it out. And we do that for any curve that's greater than 40%, 40 degrees, they call it. And it's really showing that it's continuing and it's really compressing those lungs. And we do something called a Harrington rod or Lukey rods. And what they do is they put a rod and attach it to the spinal column and try to get that spine as straight as possible. Osteomyelitis. This is when, maybe you've just stepped on something at a scratch, and I've seen a lot in toes and fingers where they didn't clean it good enough, and then the infection got in, and then you started seeing those red streaking, fevers, and of course we do CBC, and we're seeing the elevated white count or leukocytosis. So we're going to do, of course, all the cultures, et cetera, And how do we treat this? Well, these children have an infection in a bone, and it's really, really difficult to get rid of. So it could be 3-4 weeks of IV antibiotics or several months, depending on it. And because it's usually a staph infection, it's vancomycin or amikacin or gentamicin. Remember, all those sins, we have to worry about what? Hearing and kidneys. Those are the two things that it does affect. So we're going to be doing peaks, we're going to be doing troughs, we're going to be monitoring their renal status, and of course their liver with all of this. And with osteomyelitis, we need to immobilize whatever that limb is. These children, because it's bone immobilization, need high protein. And that high protein helps with healing in their diet. Ewing sarcoma is a bone tumor. Now, we heard about an osteosarcoma. That's the femur, right? Well, this is, it could be a scapula, it could be a jaw, and it gets really big. And you'll see it just because it raises high. And how do we treat it? Well, it's basically like the other cancers. You know, if we can take it out, we take it all out. But radiation, chemo, in order to shrink it, and then to take it out as best we can. And of course, our prognosis is always hasn't metastasized yet. Of course, if there's metastasis, then there's going to be more of a problem to cure it. JIA, JRA. Now, children do get, juvenile idiopathic arthritis, and it's usually about ages 1 to 3. Many times we don't see it. So many times we don't know it. But there are things, certain signs and symptoms you will see. Now, in the morning, these children are stiff. I mean, just like adults, right? Adults with arthritis, rheumatoid arthritis, like me, I'm stiff in the morning. It's hard to move. I need to sit there. I need to stretch. I need to touch my toes, all those things to get myself moving. Of course, it's hard to walk. Maybe I'm limping or gimping a little bit. And then, of course, your joints. When it attacks the joints, they'll be swollen. I mean, I got one finger that's crooked at one joint because it has attacked it. Sometimes the fingers get really disfigured, or the toes. It's trying to get treatment quick. And then there's something called uveitis. And uveitis is the redness of the eyes. So they need yearly ophthalmology consults to look at their eyes. Now, the problem with rheumatoid or idiopathic arthritis is there's just not one test that tells you they have it. You know, I'm a nurse and I know just a little bit about medicine. It took them 8 years to diagnose me. I was fibromyalgia forever. You know, when you tell them, no, you're not, it's not that. Would you listen to me? Well, finally, they did this test called a CCCP, and they did the arthritis factor, and they both were like 10 times off the chart. And they're like, oh yeah, you are rheumatoid arthritis. And of course, what do? They put you on treatment. Now, with arthritis, there's an inflammation. So all your inflammatory factors go up. You'll see your SED rate up, your CRP up. These are things, white cells go up when you're really having a flare. And the goal with children, adults, any of them, is to make sure that they can move as well as they can. You know, keep them up, moving, prevent those deformities, and try to minimize the pain. I mean, sometimes you could take these injections weekly at home. Sometimes you have to go, monthly in for infusions. I mean, that's what I have to do. Humira, Enbrel, Cimzia, none of them worked on me. So now we're trying infusions, and I'm probably on my 8th different try, trying to find that one. That's how frustrating this can be for parents, and for the children. They just want to get up and go without hurting. Now, pain, we treat it with NSAIDs. I'm allergic to NSAIDs. I get this really rash all over me, and they told me you cannot take them. Okay. So I take Tylenol. You can put them on anti-rheumatic drugs. Steroids can be used. Now, steroids, again, have all those side effects, Cushing's, right? The swelling, weight gain, all of that stuff. So you have to be careful. And that's usually used only when there's a big flare. And then methotrexate is usually combined with it. You know, trying to get this child, this adult, a little peace of mind to be able to move and to be normal. Because in any kid, you want the kid to be normal. Physical therapy, occupational therapy. I mean, swimming is a great thing here in Florida, something you can do almost 12 months a year. Try to keep the pain down, you know, and there are children who love heat. I love cold. And whatever works, that's what you use. And that's what I have always told them. You know, let the kid know that, you know, there is relief. You just got to find that combination. Just keep telling me how you feel. Just keep doing what you're supposed to do. You know, be compliant with your therapy, and eventually it'll work. Now we have JIA, which is the body attacking its own joints. And now we have lupus attacking all the organs. This is usually in girls. These are that pre-adolescent, adolescent, more common. They think maybe it's that hormone. Maybe it's that going through puberty. They don't know. But we do know it could be due to stress, infection, and sunlight is a big thing. No, in Florida, that's a big thing, that they need to use sunscreens and they need to limit the amount in the sun. So in Florida, that would be a bigger deal than maybe up north. Those nice red rashes, sometimes when they start to flare, you'll see them vomiting and diarrhea, pain in places they normally don't get, almost like arthritic looking pains. But then they're going to go into being forgetful, not being oriented, then it goes seizures, et cetera, et cetera. So these are things which we would consider a flare. We treat them with steroids. And then there are other types of medicine we do use, the anti-rheumatic sort of things, depending on the child. So again, you know, have that kid be the kid that they want to be, but again, protect them from sunlight, which is a big deal, you know, and let them, you know, be a child. So Kristen, 10 years old, sustained a fracture in the epiphyseal plate of the right fibula when she fell out of a tree. When discussing this injury, with her parents, the nurse should consider what? Which one? What is an epiphyseal plate?
Is it B?
Yes, it is. Remember, it's all about growth. Epiphyseal plate, remember, it grows, and we want that bone to be the same size as the other side. Now, neuromuscular. Neuromuscular, you think of cerebral palsy, right? It's all neuromuscular. It is basically something that's happened that's a permanent disorder, movements, postures. And it could be from mild to severe. It could have been when they were being developed. It could be at birth. We don't know. And it is the most common permanent physical disability in children. Many of these children, because it is a neuro issue, also have epilepsy. So you'll see a lot of them on those anti-seizure drugs. What's causes? Well, the brain was formed wrong. Something happened, there was an occlusion, so hypoxic episode, okay? Some sort of degeneration, low birth weight, intraventricular bleeds, right? But again, anoxia, hypoxia. Could be at birth, they got stuck and they had to hurry up and do a C-section, and that hypoxic episode causes cerebral palsy. So when we're trying to evaluate these, I mean, of course, premature children, we always evaluate, looking at it, seeing if we're seeing any signs of them. Now, as they get older, it's easier to see that hypertonicity and poor posture. As a newborn, it's harder, okay? That would be looking at developmental progress, and it's not what they should, the grasp, the fine grasp, the gross motors, it's not going to be where it should be. And then they start looking more. How do we treat it? Therapy, speech, physical, occupational therapy, and maybe medications. It could be something for the spasms, could be something for seizures. And if we have a child with cerebral palsy, and especially if parents want another child and want to know how this child got it, metabolic genetic testing should be done. Now, my favorite child at the clinical site where I used to do clinicals for at Fortis College was Jonathan. And he looks just like this boy. And he was severe, spastic cerebral palsy. And this little boy would see me and the smile would go ear to ear, look at me, and he would just start shaking. It was like he knew I was going to give him a hug and a kiss. This kid knew me, could see me across the room, nonverbal. How do I know? Man, that kid showed me in every other way but verbally. They gave him a pad where he could talk to me through these pads, the March of Dimes, and what they've done is amazing. We're going to see those delayed fine and gross motor. We're going to see those muscle tones. They're not going to be able to feed themselves. Many of them can't eat. They can't swallow. They don't know what to do with those muscles in the mouth. So many of them have to be taught how to walk, or have braces on to be able to do those things. Now, what we want to do is keep them from being immobile by themselves somewhere. We want them around other children. So we give them some sort of locomotion. Now, this little boy here, he's got a trike, right? But look, he's got those braces on his ankles and lower legs that helps him be able to pedal. He can get around. He's happy. Put him in a wheelchair or maybe an electric wheelchair. Give them mobilization. It really helps them also. And, years ago, the Cerebral Palsy Foundation, didn't do what they do today. Today, we teach them. We teach them colors and shapes and reading and things that were never thought possible before. I mean, little Jonathan is 7, and he's just learning colors and shapes. But they used to just feed them, bathe them, put them in a chair, put them in front of a TV, and that was it. Now, I'm talking 50 years ago when I first got involved with these children. So today, what we're doing for them is amazing. And many of these children with mild CP can become productive. They can, get jobs and maybe live alone, maybe not. So giving them every capability they can is what we do for these children today. As I said, ankle foot braces. Sometimes we use orthopedic surgery. Sometimes we have to do tendinotomies to decrease those spasms. They use Botox. On Jonathan, they use the levodopa carbidopa that they use in Parkinsonism. That's shaky, and it did decrease, and it was amazing. Their mouth, remember, they don't know how to use mouth. So making sure that mouth, that they brush their teeth a lot, very, very important. And again, therapies. As I said, most kids can do okay with cerebral palsy. If we catch them early, we get them in therapy. There are a few that are severe that won't, but at least we can let them have something. The care management, like I said, families at home are going to need help. Many of them are G-tube feeds. Make sure they have all their equipment. Make sure they have suction there. Make sure they have a bed, a commode, a wheelchair, whatever they need, or maybe a nurse at night, a sitter at night so they can rest. Now, myelomeningocele, you've heard me talk a couple times about this. Myelomeningocele is when the lumbar spine doesn't close. Now, we've heard about the tummy, gastroschisis, and the bladder exstrophy, right? Well, flip the kid over, low back. This is the spinal cord and the meninges are out into the open air. There's all different types of them. The one thing you just need to know is the overall concept of them, which is myelomeningocele, okay? So it doesn't close. They think it's due to this early formation, 3 to 4 weeks after they're conceived. We think that neurotube is made and it didn't close. So it's open the whole time. It could be to maternal obesity, diabetes, or a low B12, they think. Genetic, maybe. So this child is born. If we know this kid is a myelomeningocele, this kid will be a scheduled C-section. And of course, they'll have neonatologists at the bedside, to catch these children at birth. And our first goal on these children, after taking care of airway, et cetera, is to prevent infection on that neural sac. These children immediately will be on a latex allergy, which means some of these kids do have a little sensation of their low extremities. Many don't have any. So again, if they have no sensation, they don't have bladder control, they don't have bowel control. So we need to monitor those things. Some of these children, as they get older, need every 4 to 6 hour catheterizations. So we do not want to use latex anything because you can get severe latex allergies from it. With these children that can't have decreased sensation in their lower extremities, these kids will get physical therapy, keep it as strong as they possibly can. And they'll probably be in a wheelchair for life. Many of them will never walk. So this kid is going to be that motorized kid on that wheelchair in the hospital, zipping around, and you're going to say, what's wrong with this kid? This kid looks perfectly normal, because they're normal. They have absolute perfect intellect. Now, sometimes that myelomeningocele and the spinal column and the cerebrospinal fluid doesn't drain right. Many of these kids end up with hydrocephalus. This is a child that would get a ventricular peritoneal shunt because it helps with the drainage of cerebrospinal fluid because it was born on the outside. These kids will be positioned on their abdomens, but again, in a controlled environment with a monitor and an O2 sat monitor on. Now, let me tell you about Manuel Louis. Manuel Louis was a newborn and his back looked just like that. And we had different rooms of NICU, room 1, 2, 3, and 4. And I walked into room 1. Everybody, other nurses had something to do or get something. I was in there alone, and I saw this mother crying over this child. So I'm not going to let her cry alone. It's not my kid, but I'm going to walk up to her. So I did. And I said, what's the matter, Mom? She goes, well, the doctors don't know if he's going to live, and I don't understand. And I said, Mom, what's happened, it was born on the outside. He's going to be beautiful. He's going to be perfect, but he might have decreased sensation in the lower extremities. And something, I think you're going to do the best you can for this kid. So I want you to do something. Sit in the chair. I wrapped the kid up, put it in her arms, and I said, isn't he gorgeous? Look at that hair. Here, comb it. And I gave her a brush. 14 years later, she found me in the ER and said, get her, get her. And they called me Betty Boop, okay? Go get her. I want to talk to her. She'd been looking for me for 14 years after this. I came out and she looked at me and she showed me her keychain, which had a picture of me holding him as an infant. She carried it for 14 years. Manuel Louis had just gone to his 8th grade prom. He was an A student and he wanted to hug me too. That's what you can do. And it wasn't my patient. So these kids do beautifully. They can. They just need that parent to give them that oomph to say, you're going to do the best you can. And most parents will. They, especially sitting there crying about their poor child. So she said, I will be eternally grateful for you. Your words stuck in my head forever. So makes me cry every time I think about it. Now, why do we get neurotube deficits? Well, we know every time we're going to get pregnant a month before we get pregnant, right? No, but we should be taking folic acid 0.4 milligrams a day. It does help with it. All right, let's go into some spinal muscular dystrophies. Word-Dig Hoffman is also called a floppy infant. They look like a frog. They have no muscle control. It's progressive, and they usually die before the age of 2. They don't eat, they don't cry. They're just very weak children. We start to see it about 2 months old, because remember now it's progressive. So at first they might have a little bottle, maybe with some difficulty, but we teach them how, and then they start to go downhill, and then they die. Duchenne muscular dystrophy. If there's one muscular dystrophy you should know for Hesse, for NCLEX, I don't know why, but they love picking on this one, okay? Duchenne muscular dystrophy is males, ages about 3 to 7. And it's called a pseudo-hypertrophic muscular dystrophy. What happens is all of a sudden they start to get weakness and falling over. And you could see that their muscles, these hypertrophic calf muscles, like really thickened muscles, and it progresses. Now, our goal is physical therapy. It's also they can get a little bit overweight for lack of activity. So watching their diet, we don't want them too heavy because it's going to be harder to walk around. And because it's a muscular progressive weakness, they usually die in their adolescence from respiratory or cardiac failure. Now, you've got this little 3-year-old kid who's showing signs of this muscular degeneration. We need to diagnose it. So we do what we call an EMG, or electromyography. And they put these little probes on, and they give a little shock of electricity, and we watch the muscle spasm. Or does it spasm delayed? Or is it not as strong as it should? Remember, if your kid is going to get an EMG, when they come back, or even before they go, they should have some Tylenol or some Motrin, because you get a lot of muscle stiffness afterwards, and it's uncomfortable. I had one. I'm telling you, you are uncomfortable afterwards. I had a neck issue, so they did my upper extremities, and I was uncomfortable afterwards. Signs and symptoms, that waddling gait, falling over. And do you know what Gower sign is? It's what I do every time I get on the floor. I put my hands and walk up my knees, my legs, till I can get myself up. It's Gower sign. So I crawl up myself in order to stand up straight. These kids do it. And again, they're going to have some mental impairment. As I said, obesity, so we need to watch that diet. Now, this comes from mom. It's an X chromosome, so genetic counseling. If this parent wants to have another child, they should have some this hereditary metabolic looked at to see, chances of it. But most times, if they have another boy, chances are it's going to have Duchenne muscular dystrophy. So again, let's keep those muscles moving, keep them flexible, keep them up and moving as best we can. And of course, give that genetic counseling for the family, because mom's going to feel bad because it is X-rayed from the X. So Guillain-Barré, have you heard about that in your MedSurg 2 yet? Guillain-Barré is, again, a neuromuscular disorder. Usually you'll see this following some sort of viral something in the last month. And what it's called an infectious polyneuritis. And what you're going to see again is muscle weakness. These are older than Duchenne, boys or girls, doesn't matter. And you're going to see that muscle tenderness, weakness, and you're going to go from the feet and it's going to move up. So then your knees hurt, then your hips get weak. Then you might become incontinent or get constipated because you can't push, you're not feeling it. Those nerves are damaged. And then it goes up and it hits your phrenic nerve and paralyzes it, and you can't breathe. It's like getting a muscle relaxant for OR where you completely can't move. That is what Guillain-Barré is. The mind is wide awake, but you cannot breathe. So with that being said, what are we going to be watching? We're going to be watching respiratory status, right? Because that's the most severe thing that can happen. We're going to be treating this with intravenous immunoglobulins. Sometimes they're steroids or plasmapheresis, maybe, but we will be supporting their lungs, usually with a ventilator. And if it goes on more than 2 weeks, they'll get a trach, because you can't have endotracheal tube in there that long. I had a nursing supervisor that this happened to, that she had a sick, she came into the ER complaining, she went into respiratory arrest, they admitted her, and they found Guillain-Barré. And as nurses, we had to take care of our supervisor in the hospital. She was on a rotor-rest bed, ventilated, and then all of a sudden, she started to take her own breaths. So we knew that it's going to go down. So it's ascending when it occurs, and then when it goes away, it goes down. So all of a sudden, you're going to see her take some breaths. Then you're going to see her start wiggling her hips, her knees, her ankles, her toes, and then they're going to need therapy because of how long they were in bed, okay? Tetanus, step on the rusty nail, right? How often do you get a tetanus shot today? Every 10 years now. Used to be every 3 years, every 5 years. Well, now it's every 10 years. And they also give it with a diphtheria booster today. That's something they added on, it was like 7 years ago. And I think it's a great idea. It is preventable. We need to, number one, clean the wound well. And then we need to go get our tetanus shot or the booster. Tetanus, what do we see? Well, tetanus is all upper airway jaw muscles. It goes into a spasm that is so painful. And then you can't breathe and you can't swallow. And it's, of course, your airway is gone. So when you can't take a deep breath, you can't swallow, and this pain is like beyond horrible, what do we do for this? Well, we give the tetanus vaccine, we give the toxoids, and this will help with it. We also put them on muscle relaxants and let it go away because this is painful, 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 painful. So again, we're going to regular treatment that doesn't go into the point of ICU and respiratory distress. We're going to clean the wound with soap and water. We're going to get our booster, and that's going to help prevent it. As I said, when you don't treat it, you're going to be put in the ICU because you're all respiratory. We're monitoring the respiratory. We'll give that immunoglobulins. We're still going to be cleaning wherever that wound was that got the tetanus into you, but we're going to be giving that muscle relaxant. And I'm talking Pavulon. This is where you are completely paralyzed, like as if you went to the OR type of thing. And eventually it comes back. Botulism. Botulism is food. Now, botulism, the one thing that we're concerned about is children, especially your infants. There are some cultures that believe if an infant doesn't have a bowel movement the way they should, you give them a little bit of honey or a little corn syrup, and it's going to help them move their bowels. It's absolutely the wrong thing to do. Number one, was that corn syrup or that honey, was it pasteurized? Was it sterilized? How long has it been in the bottle? How long has it been on your shelf? So we would never, ever, ever do that. I know up north, we used to bottle our own tomatoes and vegetables and stuff for the winter. Did we clean those containers well enough? Because that can also cause it. Again, what do we see with these children? Well, it starts like within a day, day and a half after the ingestion, and you're going to start with being weak. And again, it starts with speech, something going on, and vomiting. And again, it goes into respiratory issues, where I'll be given again botulism, immunoglobulins. We'll be watching them, their respiratory, and we're going to make sure that they get proper nutrition, because a lot of these are your younger kids. Spinal cord injuries, you know, just like that little 16-year-old boy I mentioned about, that C5, C6 angulated fracture, that I was the primary nurse. That neck was my #1 priority. And it was, of course, he slid into third base, his head hit a knee, and the stands heard a crack. And that, it was literally angulated, it should be straight. I was like, oh my goodness. We did an MRI in the ER, unheard of, which we had to pick him up and over and on to the MRI machine. And we did that. And it really, this kid, all of the diligence, making sure, and let me tell you, nobody was touching that kid without me saying when and why, way and how. And the kid did benefit from that. It can happen. How about birth? We're pulling a neck, right? Whatever the case is, spinal cord, make sure we immobilize it and keep that area immobile, so we decrease the amount of injuries for it. Remember, when we're talking at different areas, remember, always respiratory will always be our thing. There are, you have neurosurgery there, general surgery there. We're going to be having the ER doctor, the general doctor, x-ray, CAT scans, laboratory. A lot of people are running into this child. So keep that kid calm. Let them know what's going on, because they are scared. You know, that little 16-year-old boy could barely move his right foot and couldn't move his left foot at all when he arrived to the ER. And when I went to see him in his room 2 weeks later, he just had a little bit of decreased sensation on his left foot, and he was going to therapy, inpatient therapy, and he made it. I saw him a year later. He'd come to visit. So a progressive infantile spinal muscular atrophy, and the most common paralytic form of floppy infant syndrome is which one? It's not Duchenne.
B.
How about C? How about C? Floppy, right? I've never seen a floppy, thank goodness. I've seen many of the other things that were here today. Any questions? Okay, who wants to win a Kahoots? Victoria, it's your turn. Yes, it is. Esther? Okay, Douglas, are you on top today? All right. Samantha? Nikki got it. Let's go. Get up top. Watch out, Kelly likes to win. Right, Kelly? It's okay. I always like to win. Isn't that our competitiveness? All right, let's get her going. Musculoskeletal neuromuscular dysfunction. A multi-select. What is the priority for a nurse to assess following a cast application? The kids broke the arm, the leg. And not only for the nurse to assess, to teach the child and the parents to go home with. All the above. Remember, there's 6 P's, so it has to do with anything, movement, numbness, swelling, pain, all of those things. What should the nurse monitor after a soft tissue injury? Now, a bruise might just be a simple bruise, but remember there's crush injuries and things that could make that soft injury, the outside, not look as bad, right? So you're always going to be checking those neurovascular signs. If it's capillary refill, if there's pulses, can we feel it? Because it could occlude blood vessels, and we still want blood to flow through there. And a big ecchymotic bleeding episode can occlude blood vessels. A fracture that penetrates the skin is called. It's called a compound or open fracture. So if the bone has hit the air, how do we treat it? It's going to be antibiotics for sure to prevent infections. What is the priority in nursing care of a child with a compound fracture? Many times it's the kid got their fingers or hands slammed in a car door. That is a common one that you see. And our priority is infection. Yes, we want to take care of the pain. Yes, we want to monitor neurovascular checks. But if we have an infection, it could go systemic. Osteomyelitis, all of those things. What is the priority nursing care for a child who fell off a second floor balcony? You know, I actually had a 3-year-old come in, a little girl who fell off second floor balcony at her apartment. And remember, our first number priority is if they're going to have a neck brace and they're going to be on backboard, we need to keep them mobile. We need to help prevent them from going into neurovascular deficits and paralyzing these children. Principles of managing soft tissue injury include rest, ice, compress, and elevate. Yes, yes, yes. Epiphyseal plate fractures in children may what? And as I said, many of these are in the elbow, where I've seen the biggest ones. Falling off of the monkey bars onto their elbows, off the slides. And again, epiphyseal plate is all about growth and that bone growing the way that it should, so it matches the other side. So the right and left arms will be the same length. What findings for a patient in skeletal traction indicate peripheral neurovascular impairment? We have no pulse. We have a problem. So this is something that needs to be reported to the physician so that we can get that blood flowing immediately, or else there'll be death of tissue somewhere. A multi-select. How should the nurse care for a skeletal traction for a child with a fractured femur? Now, skeletal traction with a femur probably is a Steinman pin, where they put a pin through around the knee, and it holds that bone straight. And it goes up and it connects to weights, again, to hold that bone straight, right? So we want to know every shift what the weight it was on there to make sure nobody took it off. I mean, visitors come, people come, they could have removed a weight, and you don't want that. And also, you need to keep it free hanging, and it should be on 24 hours a day. We don't touch the weight. When caring for a 9-year-old in Buck's traction, what action by the nurse is correct? Buck's traction is similar to your skeletal traction with a fractured femur. It pulls the leg, keeps those bones together instead of having all those muscle spasms. So again, we are always going to be checking that capillary refill. We're going to be checking pulses to make sure that there is blood flow all the time. A multi-select. Which assessment indicates an infant has developmental dysplasia of the hip? It's one of the first things the pediatrician does when they're looking at your child after they listen to them. They'll take their legs and push them up and down, wanting to see, is it in the right place? So we're going to see those asymmetrical leg folds. We're going to see a positive ortolani. You hear that clicking. Moro is a startle reflex. Babinski is the feet that will splay, just like adults. It has nothing to do with that hip dysplasia. Remember, we're going to see a difference in the length of the leg too. What position do you put the legs of an infant with hip dysplasia? So we want to see abduction, okay? We want them up, close to the body, up in that little Pavlik harness, and that is called abduction. What statement by parents indicate more teaching regarding their 2-month-old infant with club foot? So we need to start that treatment as soon as we can, because remember, infants are very flexible, their bones, when they're very young. And you're not going to put a kid every month. Remember, it's every week they need to get a new cast, okay? You're going to have follow-up care until they're grown to make sure their feet are good. And again, coming in every week. So not every month. That's way too long. A multi-select. Osteogenesis imperfecta. It is called brittle bone disease, and those long bones can be crooked because of all of these breaks. Actually, there has been some cases that they felt this child was abused in child abuse until they found out it was osteogenesis imperfecta, so it can happen. And you're going to do very gentle physical therapy because these bones will break. Just lifting them up, your fingers going into ribs can crack ribs. What is the pathologic cause of leg calf perth disease? This is an ischemic aseptic necrosis, which means no blood flow is going to the femoral head, and it's due to no infection. So we treat it, bed rest, NSAIDs, and maybe some traction to hold it still. And that's it. And it will eventually go away. Kyphosis. Kyphosis is the upper back, and it's called humpback. Lordosis. Remember lordosis you see with Duchenne muscular dystrophy, along with all that muscle weakness that goes on. And it's the L for lumbar, L lordosis, that inward curve of the lumbar spine. Scoliosis is. When you see scoliosis, S for S-shaped shape to it. Remember, there's different degrees of it, different treatments. About 40 degrees, you're going to do surgery. Less, you're going to have bracing, exercising. It all depends on how severe. An adolescent with scoliosis that have up to a 45% curvature of the spine would need to do what? So everything below that. So what we're going to do is up to that point, we can put them in a brace 23 hours a day, 40, 45, that's rate at the maximum that it can be. And then we're going to look at if it continues to be curving, then of course we're going to do surgery. But if it stays there and below, then we could put them on a brace 23 hours a day. And of course, physical therapy exercises need to be done to strengthen the muscles. What is osteomyelitis? So it's an infection of the bone. Absolutely. And it could be just stepping on something, and it could be the big toe or the finger, and all of a sudden you start being sick with it. Goals for juvenile idiopathic arthritis includes what? JIA, the old rheumatoid arthritis, body attacking itself. So when we have JIA, you know, and this child is suffering with morning stiffness and, you know, can't ambulate that well and could even have the red 9 uveitis. All our goal is to prevent that and especially reduce that joint pain and swelling to prevent all of those deformities that can happen with it. Keep the kid as normal as we possibly can. A multi-select. What might you anticipate for a child diagnosed with JIA? With a child, you're not going to see a rash. That's lupus, okay? But the uveitis, difficulty walking, especially stiffness in the morning, and of course, joint disfigurement as it progresses on. A multi-select. What can help a child with lupus prevent exacerbations? Of course, the sunscreen, the sunlight, and prophylaxis before any sort of treatments or surgery. Diet has nothing to do with it. What organs can lupus affect? All of your organs, every single one. What is cerebral palsy? Cerebral palsy is those body movements, coordination, and spasticity on some of it. They just can't control their body's muscles. Their brain doesn't connect. A myelomeningocele. That's Manuel Louis. And it's that hernia of the spinal cord and the meninges. Let me give you a visual. So if this spinal cord with all of the attached nerves is stretched and pulled out of the skin, it's stretched nerves. Those nerves are to the lower extremities. So you could have decreased movement in the lower extremities, but any nerve attached down there could be decreased function, like urine and, you know, your bowels. So that's how I remember those problems with it. Infants with myelomeningocele demonstrate what? So they're not, maybe not be able to move as well. Definitely they're going to have some sort of sensation decreases there. So again, that depends on how much, what we need to look for, check their urine, check their stools, physical therapy, whatever they need to keep them strong down there so they can move around. Myelomeningoceles have decreased motor and sensations of the lower extremities. The nurse should monitor closely what? Urinary retention. Many of these kids do require catheterizations for life. In fact, they're even taught as they get older to do it themselves. And if we don't, that bladder keeps filling and filling and filling. They don't feel it. Again, also, they have to monitor their bowels too. A key feature of Duchenne muscular dystrophy is what? I mean, I already told you lordosis is one of them, right? And we know if they have lordosis, has everything to do with muscle weakness, and that is that progressive muscle wasting. Yes. What is one of the procedures that a child with possible Duchenne's may need to diagnose the condition? I mean, if it's muscle weakness, we need some sort of an examination that tests muscles. And the one that does to test muscles is the EMG. It takes a little zap of electricity and it watches muscles contract. And it measures how quick it contracted and how strongly it contracted. Remember, they need something after it. It hurts. They're going to be uncomfortable. How is Duchenne muscular dystrophy inherited? It is the X-linked recessive. It comes from mom. Again, if this child, they're diagnosed and the mother wants to have another child, they need to go and get testing, and she needs to know that it did come from her. In caring for a patient with Guillain-Barré, the priority concern is what? Remember, this is ascending from the feet up. Nerve is going to become numb. So it's going to be falling down, shuffling, incontinence, constipation, and then it goes all the way up. And so what's our big concern? Always airway, airway, airway. And they do end up on ventilators for a period of time. And then we know it's going to go descending when it starts to go away. So they'll start taking some breaths, and we could see that on the ventilator. For a patient suffering with Guillain-Barré, they would complain of weakness that was what? And we call it ascending because it comes from the feet and goes upward. When it's going away, it's descending from the lungs, from the neck, then it goes downwards. Treatment for Guillain-Barré include So we are going to put this child on some IVIG, immunoglobulins, and respiratory support. Maybe they're going to be on some steroids. Remember, Guillain-Barré is due to a viral disease, so antibiotics are going to do nothing. And heparin, for what? It's not because of that. I mean, maybe they do prophylactic to prevent things, but treatment for Guillain-Barré is IVIG and respiratory. What type of cerebral palsy causes hypertonicity and poor fine motor skills? My little Jonathan. and it's called spastic. Spastic means they're spastic. They're really hypertonous, like they're really shaking, and that is called spastic. Probably when you think of cerebral palsy, that is the one you think of. It's called spastic. What priority action should a nurse take to a patient with a suspected spinal cord injury? Again, that spinal cord, you need to keep it immobile so you can prevent further injury. You should get a tetanus shot every how many years? 10 years. Good job, guys. And it comes with that diphtheria with it too today. What is a symptom of tetanus? And it's all that tense in the jaw, severe muscle spasms. You can't eat, swallow, breathe. It's called lockjaw. It hurts. And last question. Most common causes of spinal cord injuries are what? Accidents, motor vehicle, driving, sports, those are probably the most common that we've seen. And of course, kids jumping off of balconies like I've seen. AG, number 3, good job. Number 2, CJ, my grandson's initials. And Smile. Kelly and KV, good job, guys. Please, please sign your attendance attestations. Get that done so you don't forget. If you need anything, let me know. As I said, anything that was due last week that you didn't get in, please submit it. I will accept it till Sunday. I'm still working with some of you on your pediatric assessments. They were turned in on time, but maybe I wanted you to correct something for a better grade. If you get it in by Sunday, we will. After Sunday, I cannot anymore, okay? I hope, yes?
Sorry, quick question.